Welcome, everyone. We are going to wait 2 minutes for people to join the call. After that, we will start with the presentation. So if you already joined, we're waiting 2 minutes. Okay, a warm welcome to everyone who has joined. I think we can get started now. My name is Zainab Naimi. I work at the Department of Maternal, Newborn, Child, and Adolescent Health in WHO headquarters, Geneva. I'm delighted to welcome you. Before we proceed with the webinar, we have some house rules that are also available at the top of the chat window. So everyone is muted on entry and we only unmute speakers. After the presentation, we will have a question and answer session. So please post your questions in the chat room and send them to all participants during the presentation. My colleague, Benedict Walter, she will moderate the questions and read them out loud in the question and answer part of the webinar. If you have any questions that we don't have the time to answer today, we will share them with the speaker of today's webinar and answer them on the website in the following days. So the Network for Improving Quality of Care for Maternal, Newborn, and Child Health has been organizing a series of webinars on selected topics on quality of care from a country perspective and on quality improvement implementation science. For the ones of you who are regularly following these webinars, you will remember that the first series was about points of care quality improvement, and the recordings from all of these webinars are available online on qualityofcarenetwork.org. Today's session is the third session in the second webinar series that highlights examples on quality improvement work from the 9 countries that are leading the Quality of Care Network. You will remember that we started this series with the experience of the National Quality of Care Network in India, where Dr. Vikram Dutta from Lady Hardinge Medical College in New Delhi shared their experiences with establishing a self-sustaining learning network across hospitals in India. The second webinar was in collaboration with Global Learning Laboratory for Quality UHC, and the focus of this webinar was to explore how quality of care for mothers, newborns, and children serves as a pathfinder for enhanced quality of care services. Today's webinar will focus on the use of mentoring and supervision of quality improvement teams, as well as community involvement for quality improvement. More specifically, we'll be hearing about the lessons from the Maternal and Neonatal Implementation for Equitable Systems, the Manifest project that was implemented in 3 districts in eastern Uganda. Our speaker is Dr. Suzanne Kiwanuka, who's a senior lecturer at Makerere University School of Public Health, Uganda. She's a health systems and policy expert with interest in human resource policy and practice, maternal and newborn health, and knowledge translation. We'll give the floor to Dr. Kiwanuka to give her presentation.
Okay, thank you very much, Zainab. Good afternoon, everyone, and good morning, where it applies. As introduced, I'm Susan Kiwanuka. I'm going to take you through 30 minutes regarding the Manifest program and how it improves quality in rural Uganda. My presentation outline, I'm going to give you an overview of quality improvement in Uganda, and then I will introduce Manifest and how Manifest worked. My presentation will include the methods of collecting data to evaluate Manifest, as well as the outcomes themselves, lessons and challenges regarding supervision, mentorship, and community engagement. So as we all know, quality is at the center of the health system. All the outcomes which can be achieved in the health system can only be achieved through good quality care. And I won't spend too much time on that. We've all seen or at least I'm sure many of the listeners are familiar with the system building blocks and components. So the past 2 decades have shown slow progress in the achievement of health outcomes in Uganda. We have under 5 mortality rates at around 137 deaths per 1,000 live births. We have infant mortality rates at 75 per 1,000. And of course, the stagnating maternal mortality. All this has been attributed to the increased demand because of the exploding population, the increased number of districts which expand the necessity for increased oversight, as well as the generally weakened health systems which provide poor quality care. In Uganda, quality of care has been an emphasis since 1994, and the Quality Assurance Program was developed to support decentralization when it was first initiated. Later on, by the year 2000, the Yellow Star program was introduced. However, the Yellow Star program was mostly delivered under a project approach. It had its own staff, it had its own tools, it had its own implementers, its own evaluation schedules. So it was separate from the system, and of course, it wasn't sustained. Uganda's current quality improvement policy states that quality improvement models should all apply the principle of the iterative cycle of improvement, that is the PDSA cycle. The Ministry of Health recommends to combine the 5S as well as other evidence-based QI approaches. So most programs use a combination of one or the other. So some of them use the continuous quality improvement or the total quality improvement. In the manual for quality improvement in Uganda, the Little Steps model is also outlined. So on the landscape in Uganda, you will find a plethora of quality improvement initiatives. Many of them are project delivered, but we also have some which are delivered through the Ministry of Health under the general platform or programs. So we have support supervision, we have continuous medical education, we have results-oriented management, the client charter, we have quality control in central public health laboratories, and so on and so forth. But one of the key things which was revealed in a situation analysis of quality improvement initiatives in 2010 was that most quality improvement initiatives are donor-driven, all of them have a shared vision of improving quality of care. We have some disease-specific quality improvement initiatives. Many are project-oriented, and the differences in approach exist, but the concepts and the principles for quality improvement are largely similar across these programs. Many of these quality improvement programs are designed to be implemented periodically by supervisors, managers, and trainers. Many of them predominantly focus on quality improvement on the supply side, that is the healthcare system side. The existing few demand-side interventions focus on strengthening patients' rights, and almost none of them address community responsibilities to quality improvement. And I'll get into that a bit later, because that was one of the reasons why Manifest focused on both demand and supply side initiatives. So in 2013, Makerere University School of Public Health, in partnerships with the 3 districts of Kamuli, Palisa, and Chibuku in eastern Uganda, commissioned a study which was called the Maternal and Neonatal Implementation for Equitable Systems, and the fancy name was Manifest. It was aimed at improving maternal and neonatal health outcomes in the 3 districts, hopefully in a more sustainable manner. This program was funded by Comic Relief and scheduled to end by April 2016. The 3 districts are districts which are a number of kilometers away from the main capital, and there is a summary of the size of the districts and the population. I think I deleted that. The population is not given here, but it can be obtained from some of the publications which emerged from this work, as I'll share later. So Manifest, like I said, on observation that most quality improvement initiatives were mainly focused on supply side initiatives with persisting demand side gaps, we decided to focus our intervention on both sides. So on the demand side, it was community mobilization, sensitization, empowerment, while on the supply side, we focused on provider management capacity building, as well as facility supply provision. We used a participatory action research approach, which was aimed at promoting local ownership, harnessing the use of local resources, as well as stakeholder participation. Why did we do that? We wanted to build local district capacity so that these initiatives are more sustainable rather than run in a vertical manner. We also wanted to empower communities to make a contribution or to take responsibility for improving health outcomes through some of the things they can do. So our theory of change touched on all aspects of the intervention, that is the communities, the health providers, the district leaders, and the households. And I'll spend a bit more time on this. So ultimately, what we wanted to do was to improve the quality of maternal and newborn care, which would result in reduced maternal and newborn deaths. So for the communities, we wanted to improve routine referral transport to support maternal and newborn care. We wanted to improve male involvement. We wanted better participation in ensuring accountability from health providers. For the providers, we wanted to improve their motivation to provide better quality services. We wanted to promote the better use of available resources, to support village health teams to sensitize communities and to supervise the village health teams. For the district health leaders, we wanted improved planning and management for maternal and newborn services, better support supervision, and more advocacy for resources for maternal and newborn health. For the households, these are the households which are usually having the mother who is expectant or the newborn. We wanted to achieve improved maternal and newborn care practices. We wanted to promote the culture of saving in order to be able to afford transport and birth items, and the increased use of transport services and the uptake of maternal health services. So when you look at this theory of change, we did a number of things in order to see how we can achieve those changes. We did community dialogues, media campaigns, community health worker visits to households, registering mothers and educating them about birth preparedness and danger signs. We also provided non-financial incentives, that is basic training, basic supplies, performance recognition, and support supervision for the health workers. But we also trained the health workers in management, as you will see later. So for our preparatory phase, we first did a facility assessment. We consulted the community, we consulted the district, we had national consultations, all of which fed into the design of the intervention. They fed into the development of tools. Then we piloted the activities, revised the tools, and then implemented. We also did midterm and end-term evaluations for this. So as you can see, hello? As you can see, the facility assessment revealed that tracer items for antenatal care services, were under par in a number of facilities. If you look at, for instance, hemoglobin tests, they were quite low. For all districts, they were below 60%. If you look at iron tablets, they were low in almost all districts. If you look at folic acid tablets, they were low. So the districts were performing well on some aspects, but they were performing pathetically on other aspects of antenatal care. So the first question is, what do the mothers get? When you look at the basic items for basic emergency obstetric and newborn care, if you look at the left-hand side of the graph, you will find that a number of tracer items were performing very poorly. When you look at emergency transport, for instance, examination lights, suction apparatus, manual vacuum extractor, those were performing very, very poorly in these districts. We also looked at tracer items for routine immunization. As you can see, these districts are more ready to vaccinate than to save a life at birth, because the items here were performing basically, well, generally better across all items than the maternal and newborn care items. So Manifest started off by providing a basic equipment to facilities. We had a budget which allowed facilities to purchase some basic equipment to supplement their gaps based on what our capacity or our assessment had revealed. And the districts were allowed to make a decision on what equipment they would purchase. We also did capacity building for the DHT members in leadership and management, and also capacity building for frontline workers to provide quality care. We also trained them in support supervision and mentoring, as I will talk more later. On the demand side, we did community mobilization and sensitization, and we also harnessed the use of community resources in order to improve awareness on maternal and newborn care seeking, to improve the access to savings and transport mechanisms existing within the communities. Ultimately, our aim was to improve the maternal and newborn care practices which contribute to the outcomes at the front line. So the results I'm going to present are based on the different evaluations we did. We reviewed records. Those were activity records within the district, service delivery records. work plans, action plans, but we also did 3 surveys at the baseline, at the midline, and at the end line to show the outcomes of our work. We did key informant interviews, focus group discussions, and we also did a validation workshop with all the stakeholders we involved. For details, you can look at the published papers. I'll give the link later, but I want to get into the specifics of the work. So for support supervision, we noted that support supervision is currently there, but there are pertinent gaps, and these include the failure to follow the full circle of QI, the lack of tools, and the limited resources, both human and financial. So what we did, we trained 204 health workers across all the districts, but we also trained 90 in management. We adopted MOH tools. One of the things we found was that the MOH tools were not tailored to the level of the facility. So some of them could not be applied at lower level facilities. So we had to adapt these tools. We trained support supervision teams for 2 days, and then we allocated specific facilities to these teams to visit consistently from every quarter, starting from the 3rd quarter of 2013 through to the 1st quarter of 2015. During each visit, the team would record the performance based on jointly developed checklists. We developed these checklists with the health workers, and the checklist checked for human resource availability, the readiness for providing EMOC services, client records, availability of individual pillars. So at the end, we scored its performance. As you can see, this is Bulangira Health Center 3, and it scored 71%. And then they would tell us the status, what is available, what is missing, or how is it performing. And then they would tell us where the gaps are. For instance, they said that this facility had only 1 midwife, and yet it had a number of deliveries, which are high. So one of the actions was to deploy more midwives to this facility through the DHO's office. So what were the outcomes of the support supervision? One of the first outcomes we noted was improved facility performance across the period of the support supervision. At the baseline, the mean scores were 43. At the second visit, it was 49, and by the 3rd time, the average was at around 63. So the scores kept on improving, but I wouldn't say that they improved for all facilities. So some facilities performed better than others generally. We also noted improved availability of supplies and services. For instance, there was an increase in assisted vaginal delivery. As you can see, the green represents the 3rd quarter, while the red is the 2nd and the blue is the 1st. So across 3 quarters, you can see that there is increases in the availability of some of these services. The increase in availability of parenteral oxytocin, increase in availability of manual removal of placenta, and so on and so forth. Unfortunately, you'll observe that some aspects still remain below the 50%. For instance, the injectable vitamin K. So the availability of that persisted across the 3 quarters. With regard to newborn care, we also observed some improvements. From our observation, newborn care was performed better than the maternal tracer items. So the only item which didn't perform well was the tetracycline ointment, which we were told that is always supplied in minimal amounts. That was the same with the vitamin K. We noted some changes in laboratory services, but of course, one of our perhaps disappointments was that items such as blood grouping and cross-matching, urine testing did not improve substantially across the period. They still remained low, and yet these are important for maternal and newborn care. So what are the lessons we learned? We learned that teams doing support supervision need to be consistent. Changing teams disrupts the flow and prevents follow-up. We need to have actions which are beyond the facility addressed. Whenever facilities have actions to address beyond their sphere of influence, they get frustrated when those issues are not addressed. The time at the facilities was inadequate because the facilities are busy. The facilities are busy, and making time to engage was frequently a challenge. Their ability to record report writing was also poor. Their report writing was not good, and over the period of time, it improved, but not to the level we would want. Medical officers never attended unless they were part of the support supervision teams. Medical officers tended to think that it is below their pay grade to attend support supervision together with the nurses and the midwives. So they thought perhaps they should have their own special support supervision. There was a persistent supplies stockout for particular items, as already noted. But we also noted that there was a lack of action at the higher levels for the bigger things. We don't know whether it was a lack of action or delayed action. So things didn't work fast. So one of the lessons we learned was to customize tools at facility level. They shouldn't be standard across all tools or all levels of facilities. Train many supervisors. They need to train as many supervisors as possible. They need to push for action at all levels, because some items on the action plan target the district leadership or the national leaders. They need to co-opt medical doctors on the support supervision team, or perhaps schedule separate support supervisions for them. It is important to recognize improved performance. It is important to use support supervision data to inform mentorship, as I will talk about later. And this support supervision should be support, not criticism. The health workers were very much against being criticized. When it came to mentorship, we viewed this as a collaborative, mutually beneficial partnership between the mentor, who possesses greater skills and knowledge and experience, and the protege, who is looking to increase their skills and knowledge. And we wanted to foster continued learning for the health workers who had been given some refresher training. So what we did is we trained 36 mentors, and these mentors were split across the 3 districts into teams which visited 2 facilities each. So each district had 12 mentors in 2 groups, that is 6, 6, and each of these 6 mentors visited 2 facilities for 2 quarters, and then later moved on to an additional 2 facilities to provide mentorship. So the mentorship also ran parallel to the support supervision. Initially, we opted external mentors to come and support the internal mentors. These external mentors were got from regional hospitals. Some of them were got from national hospitals. And after they took the district mentorship teams through the basic tenets of mentorship, then they withdrew. Okay? So the areas of focus for the mentorship in clinical service delivery included newborn resuscitation, the conduction of clean and safe delivery, labor monitoring using pathographs and clinical decision making, timely appropriate referral, and especially encouraging teamwork in facilities, as well as strengthening administrative procedures and leadership. The organizational aspects, such as deployment of staff based on workload, the preparing of duty rosters, staff accountability of time, handing over during change of shift were also emphasized. But these mentorships also emphasized health worker attitudes, because that was one of the issues which the community complained about, as well as professionalism. Mentorship was delivered in one-on-one or peer group and online. So the aspects which were focused on during the mentorship were premised on what the facility assessment found as gaps for a particular facility. And these mentorship visits were pre-scheduled by the mentorship teams together with the facility, and were comprised of 2 to 3 days quarterly and then biannually. So a typical mentorship visit had a review of improvement objectives by the team and the people on site at the facility, and they used the mentee diaries, which we developed together with the health workers, as well as the documentation journal. Then the teams would discuss how to address the areas identified to improve to the desired competencies, and then they would discuss the challenges as well as the solution, and they would review plans for the next visit. The mentorship visit also included the observation. Hello?
We can hear you. Go ahead, Susan.
Oh, it just went off. The mentorship visit also included the, good Lord. The mentorship visit included the demonstration of obstetric and newborn care skills. So the health workers and the mentors went through drills. Then they reviewed clinic-based records where they would check for quality of data, which is recorded by the health workers. They would review a case. If there was a complicated case, they would review it together with the mentors. And then they would also hold individual mentee meetings. So all the visits were documented. 12 facilities benefited from receiving these 2 to 3 day mentorships across the period of, across that period. So more than 72 mentorship visits were made across 16 facilities over 2 years' time, and more than 48 internal mentors were trained. Maybe I need to explain this. At each level, whenever a facility was mentored, the mentees would then be tasked to mentor the next level facility based on the skills they had obtained. So when we were cascading to the next level, we would go with the health workers who have been trained at one level to the next level, so that we are training more health workers in mentorship and also in skills upgrading. So more than 80 health workers altogether were mentored, but about 48 internal mentors were trained within each district. Some of the outcomes we noted were improved health worker productivity, which stemmed from improved skills and improved health worker availability. We noted clearly an improvement in pathograph use and abortion management. So most health workers learned how to use, for instance, manual vacuum extraction for mothers. We noted an improvement in blood pressure measurements. These were not routinely done for mothers, or even when they were done, they were not recorded. So we noted some improvement there, as I'll present later. And on the neonatal side, we noticed improved resuscitation of newborns using the arm bag to enhance the breathing. So some of the health workers told us, because part of the evaluation we did here was qualitative, and some of the health workers said that the mothers used to go away bleeding, but now everyone is able to do manual vacuum aspirator. They are able to save a life where there is an incomplete abortion. They also said that some staff, especially at maternity, would not fill photographs because they did not appreciate their importance. They did not know how to do it. But with the mentorship, everything changed, and they now know how photographs are filled, and they can monitor the mother and take labor seriously. So the improved labor monitoring reduced unnecessary referrals. We also noted blood stockouts reduced at some facilities as a result of improved ordering after the mentorship. We noted improved post-surgery management. Some facilities were able to obtain additional resources such as resuscitation equipment and supplies, running water. Some facilities were conducting deliveries without running water, but after the engagement with the authorities higher up during the mentorship, running water was installed. Facilities also learned how to manage maternal sepsis based on the training by the mentors. There was improved teamwork because now the teams were able to appreciate the skills imparted by the mentees, by the mentors. The human resource for health gaps, some were filled. We had some health workers redeployed to other settings to provide or to fill up the gap. And also districts were approved by the central government to recruit more health workers because of the increased deliveries at the facility as a result of the Manifest program. The other interesting thing is that facilities started having regular department meetings. This was one of the indicators we checked for during support supervision, and they actually would show us the minutes they were having on a weekly basis during the department meetings. In the past, there were no records. Some districts or some facilities developed schedules for continuous medical education, where in the past there was none, and they delivered on them. Some of them delivered on them. We found that health workers were now innovating to ensure that supplies were available. They would photocopy available forms to avoid stockouts of the forms they need to record. For instance, discharge forms, they didn't have some of the forms to keep records. So they were photocopying to ensure that they didn't get stockouts. What were the challenges? With mentorship, again, we found the continuity of teams is critical. The health workers are very busy. Staffing at the facility is not 100%. At the most, it was around 60%. So participating in this is viewed as extra work for these people, and there is limited time for mentorship. One challenge we found is poor documentation and also tailored records. The records were sometimes forged, and we were able to look at that. We found that it is challenging to build teams where medical doctors do not want to be part of the team or want to have a separate arrangement. One of the biggest challenges we found for quality improvement was referral transport. Referral transport persisted as a challenge. The lessons we learned: careful selection of mentors and tag them to facilities. Make sure that they are accountable for the performance of the facilities they are tagged to. Agree the schedule of the mentorship visits with the health workers at a facility. Close monitoring and evaluation of mentorship is important. and we are still discussing how, especially given their poor documentation culture. We found that it's critical to cascade good practices, taking health workers who have been mentored in one facility to another, encourage the other facility to improve their practices. Mentorship is an activity where resources need to be allocated, otherwise it will not be done. And also there is need to create space for doctors to be either among the mentors or a special arrangement for them to be mentored, and the use of regional mentors was also emphasized. Finally, I'm coming to my last slide. What did we do on the demand side? We realized that addressing supply side issues without addressing demand side issues is falls short of achieving the outcomes we seek in maternal health. So we sought to improve the awareness of the communities on maternal and newborn care seeking, and to improve access to savings so that facilities can have access to transport when they need it, because transport, referral transport, was a big challenge, but also to improve maternal and newborn practices. So we had community health workers visit homes, register expectant mothers, educate them on danger signs, educate them on feeding, educate them on newborn care. We had community dialogues where we educated communities. We had radio spots and talk shows. All these focused on a number of issues which were critical for the communities to learn. And some of the outcomes we found that were that while there were no home visits, at least one home visit, more than 60 households had at least one home visit, and they viewed the village health teams as a source of health information. We actually had a slight increase, about 10% increase in the 4th ANC, and deliveries at facility level increased. The knowledge of danger signs in pregnancy increased. The knowledge of newborn danger signs also increased. We also found that newborn care practices improved across the period. Actually, newborns who were initiated on breastfeeding during the first 24 hours beat our target of 70% to 96%. The challenge we had was the first delay of the first birth beyond 24 hours, where we didn't meet our target because it remained the same. We also found that women were saving with groups. There was a slight increase in savings, and they were also able to access money from savings groups to pay for their transport to the facility and to access medical bills. These are women who used organized transport in order to access care for delivery. The challenges we encountered was there is a dependency culture in the community. The population is used to free things. They are usually getting free education, free healthcare. So there is a very poor savings culture. And there was a slow linkage between transporters and saving groups, which we intended earlier to create referral transport. There was low VHT, village health team literacy level, where selection guidelines were not adhered to. Mobilization of communities was also poor for the dialogues. The take-home lesson, I am winding up, is that time is needed, and also a comprehensive package is necessary to steer the health system towards desired results. Communities have homegrown solutions, and they can challenge themselves to solve their problems. Focused on job mentorship of health workers improves skills, and the substantial involvement of district leaders in designing and implementing promotes ownership and continuity. Documentation promotes accountability. We noted that whenever we checked the documents, actions were adhered to as agreed. So a multi-sectoral approach is critical for addressing maternal and newborn issues. The last message is quality improvement is an ongoing process, but quality improvement efforts should target both demand and supply side, not only supply side. And participatory action research empowers local implementers to identify and solve local challenges for maternal and newborn services. For more details, you can look at the supplement, which Zainab already talked about, and read more about this intervention. I acknowledge the study team, which I hope is listening in to answer some of the questions, and of course the district leaders and the study participants, Makerere University School of Public Health, Future Health Systems, as well as the funder, Comic Relief. Thank you very much.
Thank you so much.
Okay,
Zainab?
Yes, Beden, go ahead.
Okay, thank you so much, Suzanne. That was very, very comprehensive, and you got quite a few questions while you were speaking. So let's see how many you can answer today while on the call. The first one is from Tausi Swedi, who works with Childbirth Survival International, notably in Uganda.
Sorry, how what?
Tausi Swedi was asking a question while you presented.
Yes.
And he or she, I don't know, sorry, works with Childbirth Survival International in Uganda, notably on maternal and newborn survival. And he wanted to ask if there are opportunities to collaborate with you to strengthen the demand side. And if so, if that collaboration will have to be in the 3 districts that you discussed, or if it can be broader in Uganda.
Okay. Do I answer that first before we move on?
Yes, please.
Okay. Right now, the manifest, like I said, manifest wound up in April 2016, but we are still actively engaged with the districts where we were working. So there is indeed an opportunity to collaborate, whether it's in those districts or outside of them. But there is a lot of opportunity to collaborate.
Thanks. Another question from the same person, from Tausi Swedi. What strategy do you incorporate to retain midwives once they've been recruited?
What strategy did we incorporate for
retaining midwives?
Hello, sorry.
To retain.
What strategy did we to retain midwives?
Yes.
Okay. Now, one observation for our country is that midwives in the public sector are really keen on staying in the public sector because of some of the benefits they see within the public sector. However, their motivation might not be that good to perform. So one of the things we did, and it's in one of the papers, was we had biannual symposia, biannual health worker symposia. During these symposia, we recognized facilities and we recognized good performers. So that was one of the things we did to motivate them, because we realized that they're doing so much work, but they only come in the spotlight when something goes wrong. So we had these symposia. In each district, we hosted about 3 symposia, and we awarded them actually with solar lamps, which would allow them to charge their phones, because we realized that they didn't have good lighting at facilities, but they also didn't have power to charge their phones. So those are some of the incentives we were giving, but we were really seeking not to give financial incentives because we are not able to provide them under the Manifest project.
Mm-hmm. Thank you. You have another question from Indira Narayanan on the quality of the implementation. You documented how newborn examination was carried out, but how did you document that it was done properly and that key issue were not missed?
Okay. During the mentorship is when we got the opportunity to see the quality of the procedure. Okay? So the mentors reported, they submitted reports to us, and they would tell us that we need to give more emphasis on this aspect. For instance, I mentioned sepsis, maternal sepsis. There was a challenge in maintaining aseptic technique in one of the districts, and mothers usually got sepsis. And when the mentors observed that, they actually shut down the theater until the district could ensure that they have aseptic technique. We also noted that when it came to newborn resuscitation and newborn examination, mentors would usually observe. Like I mentioned, a typical mentorship visit would require observation of the procedure. So the mentors would observe what is being done by the mentees and then note that down and then work towards correcting where they are going wrong. So we did not document or quantify how the mentees were failing or succeeding, but the mentor reports helped us to figure out which areas were weak. And many of those were around, for instance, post-abortion care, areas of newborn resuscitation, which were then emphasized during the mentorship visit.
Thank you. You have a very practical question from Alia Chatur on the monthly mentorship visit. Wondering whether, when you mentioned that the 12 facility received mentorship visit over 2 to 3 days, does it mean the mentors spend 2 to 3 days in each of the facility, or a total of 2 to 3 days to see all 12 health facilities?
No. Okay. So at each mentorship, I mentioned we had 12 mentors a district. So these 12 mentors were split into 2 groups. So you had 6 mentors going to one facility and staying there for 2 to 3 days, and another going to another facility and staying there for 2 to 3 days. So it was not 2 to 3 days in total, rather it was 3 days in one facility, coming in daily, supporting the health workers, working with them through cases, identifying clinical issues, identifying cases to review, managing difficult cases with them, training them. If a complicated delivery came in during that time, they would go and do it together. So the 2 teams, each team stayed at a facility for 2 to 3 days.
Yeah. You have a follow-up question on this, on mentorship from Zainab Naimi, saying that mentorship seems critical, and how do you institutionalize this function, and what was the profile of the mentors?
Okay, how do we institutionalize and what was the profile?
Yeah.
I'll start with the profile. Now, somewhere in my presentation, I actually give the composition of the mentorship team. But mentors were selected from the district, and the team had both external and internal mentors. So external mentors were specialists at national level or regional level. We had an obstetrician, we had a pediatrician, we had a gynecologist. These are at consultant level. These are the highest level of the profession to be part of the team. We also had a senior midwife as part of the team. Now these teams go down to the district, and then they would pick midwives and medical officers to join them as part of the team, and senior nursing officers. So we had teams which were built from within the team, within the district, but supported by the external specialists. And once the specialists did at least 6 mentorship visits with the district team, then the district team could continue to the next level of facility to provide the same skills and training. So how do we institutionalize? Well, I guess it's just bringing in mechanisms which are tailored to fit the context. In our context, we wanted to have more people trained in the practice of mentorship, so that we train a critical mass within each district who know beyond the basic skills and who have the demeanor to actually mentor others and to pass on the skills. So hopefully we will get to hear more about that as we continue working with the districts to see how it has panned out. But from what we know, that we were able to have more mentors on the ground because of this pairing with the external mentors. I don't know if I've answered that question, though. The institutionalization is a bit challenging.
Thank you. You still have questions coming in, so we'll take two more. And everyone on the call, all these answers that Susan is providing now, she will give in writing as well, including the question we cannot read out today because we're running out of time, and we'll post them on the website in the next few days. So you have a question from Carlin Van Herden on whether you had you experienced any challenges from staff attitude when you did this quality improvement initiative, and if you did, how did you address that?
Yes, actually, the staff attitude was mostly around us wasting their time. At the beginning, I could say the first two support supervisions and maybe the first mentorship, the staff perceived us as disrupting their schedules. But after we got into the feedback session, we tried to negotiate for the
Susan, we lost you. Okay, let's give Susan 30 seconds to see she can connect her audio again, because I see her audio is disabled. If not, she will answer all these questions on the website in the next few days. I see a question coming in for a request of a French translation. Here she is. Susan, we lost you. We lost you for the last 20 seconds or so. Sorry, if you could repeat that.
Pardon?
We lost your voice. There was no audio for the last 20 seconds or so. So if you could repeat what you just said, that would be useful.
I am also losing you, but I will just say that support supervision has been perceived by health workers to be a policing tool. So we made it clear to the health workers that we were not here to target individuals, but to look at facility performance. Then the health workers were more willing to participate and actually to give us all the information we wanted. So the feedback sessions were not really finger-pointing sessions. There were sessions to discuss what can be done to improve. So the attitude was there, but it changed quite significantly, such that towards the end, they were really looking forward to our visits because we were able to help them even change some things which they hadn't changed in the past and which were easy. Also, having the recognition at a district platform where you have the district health officer, the political leader, hand out awards for performance, kind of changed the attitude of the health workers because they realized they were appreciated. One thing I want to point out, which we were not able to change, was the attitude of the medical officers, because our support supervision was targeting teams. We could not single out medical officers, but in our setting, medical officers are kind of considered or consider themselves to be at a higher level, and they should not be mentored or supervised with midwives and nurses in one group. So we realized that medical officers actually did not join any of these support supervision visits unless they were co-opted to be on the support supervision team. So we made an effort to invite medical officers to be part of the support supervision team. Unfortunately, we found that some of them had or needed some skill upgrading, but they missed out on that opportunity during the mentorship because they didn't have the skills, but they couldn't attend the mentorship. So that is one attitude we couldn't solve when it came to the medical officers. Maybe we'll organize for them their own training and upgrade their skills, because most of the time they are the bosses and the in-charges in some of the facilities. So they need to be at a higher level of skills than all the other health workers.
Thank you, Susan. We're running out of time. You still have questions. So again, Susan will answer them all in writing, and I'll send you the link to the presentation.
Can you slow down? I can't hear your
Sorry.
question.
Sorry, we don't have the time anymore to answer more questions, but Susan will answer them in writing, and I'll send a link to everyone on this call with the Q&As and the recording of this session. Zainab, over to you.
Okay.
Thank you, Bene. Thank you, Dr. Suzanne, for a great presentation. It has been an impressive project. It highlights the importance of taking a holistic approach, and I think you demonstrated very well that involving the community is critical, the importance of both supply and demand side. And I think other messages that have come through very well is that it takes time. It's important to involve the leadership and to document as you go along and learn from it continually. Thank you, Bennett, for moderating all the participants for great questions. I could see many coming through, so those will be online, and you will receive a link, like Bennett mentioned. If you don't know the website already, it's qualityofcarenetwork.org. And if you find these webinars interesting, please share with your colleagues and join for the next one. You find the schedule also on the website. And thank you again to Dr. Suzanne, Bena, and all the participants, and have a good day.
Bye.
Thank you. Thank you. Thank you. Bye-bye.
Bye.